reconstitution. So we concluded from that in a minority urban population you can successfully treat HIV. However, African American patients really get diagnosed and initiated on therapy at a later stage of disease. We really don't know about the factors that distinguish the non-responders from the responders. We've mentioned some of the barriers to resistance, psychiatric disease, drug use, but there are many others, and that's part of the second study now. We're actually just defining the patients who've been complete responders in our clinic, defining a group who failed once, twice, thrice, and then looking at some of the differences in them. One thing that's really clear is in the United States, at least, the progress in drug development has really outpaced our ability to diagnose patients and get them into care in a timely manner. So great progress has been made in treating HIV. We still haven't found everyone. And 1/4 of the persons in the United States who've been infected still don't know it. The number of new patients in the United States and in the world continues to rise. Minority populations are disproportionately affected, and again, certain groups like African American women are seeing the biggest increases in new infection. There are big disparities with respect to the time of diagnosis and the stage of the initiation of treatment, and we really need new approaches to the diagnosis and management in these particular communities, as well as in the developing world. So it is a big problem for global health, but to think the problem is gone in the United States is incorrect. Yeah.
What are your thoughts about the initial CD count for both groups? The patients that you are seeing versus the patients that are reported in the studies?
I think it's just that in our practice, we're seeing folks who come in at very late stages of disease. Even though there is this push to try to diagnose folks who access the medical care system, that really hasn't caught on, and it hasn't really caught on in certain places where a lot of folks with limited access to health care go. Emergency rooms are a big one. If you use an emergency room as the place you go for your health care, that's a problem, and it's unlikely they're going to test you for HIV there. The CDC would like you to do that, but emergency rooms have their own problems. They're in bad shape too. The number of emergency rooms and trauma centers that see acutely ill patients has been decreasing. At the same time, the number of patients they have to see is increasing. We have an ED screening program now too, and it took years to get going. We told our emergency room folks, you know, we could do rapid testing, identify people right away, and it only takes 40 minutes to do the rapid test, do the pre-test counseling, post-test counseling, and they just laughed at us. They said 40 minutes. Most, you know, 1/3 of our patients walk out because we can't see them quick enough. And God forbid they would have to deal with someone who ended up being positive. That's a big deal, and they're not going to do a lot of counseling and psychosocial intervention in the emergency room. Now we're getting them to just send off the test, and then we're trying to call the folks later. And that's been considered a suboptimal approach because can you get everybody? Turns out that the group that uses our ER uses it over and over again, and we're actually able to get a hold of them. We've been able to get more than 90% of the people into a clinic afterwards. But the big problem is we still are finding folks at very low CD4 counts, and it's been getting worse every year. So I've been at the University of Chicago for 6 years, and we've been looking at the initial CD4 count when we start people on therapy, and it was bad when I first got there. It was 240. Yet despite these initiatives, despite expanding our clinic by 5-fold, we've now dropped down to a starting CD4 count of 140. So people are just getting diagnosed way too late. Now CDC came up with these guidelines for sort of universal testing almost 2 years ago, and no one is doing it. it was one of these unfunded mandates. They don't pay for the test, they don't pay for the counselors, and it's very, very difficult to do. Yeah?
I was just wondering, what factors do you think cause your patients to do so much better than patients in other studies?
Now, it's been shifting. That one slide I showed you is people have been failing less as the new medications have come out. We'd like to see what other clinic things can do. And one thing I can tell you is we have a licensed practical nurse who is just fantastic, and he is available to patients almost 24 hours a day. We have a social worker who helps out with all the different sorts of problems people have with access to care. She'll get people transportation, she'll get them food, she'll get them whatever they need. And when you take care of those sorts of problems, people will then be able to comply with therapy. We're not perfect either. We're still trying to figure out what we can do with certain patients. Really trying to identify what factors we really need to focus on too. But I think things are getting better for patients in the United States overall, as long as you can find them and then get them into care. Getting them into care is going to be a bigger and bigger problem. And as this becomes more of a minority disease, a disease of indigent populations, I can tell you my hospital doesn't want us to grow this population. My hospital is very upset that we're expanding the program as much as we are. And actually, the only way we're going to be able to continue to see folks that we identify through programs like the ED screening is to start to see people off-site. So we've already had to move some of our clinics from our clinic building where the university is to some off-site centers. So we have clinics now on 55th Street near the Dan Ryan, and as long as they're not there, our institution's happy. They don't care what we do, but it's going to become a bigger and bigger problem.
So is there any movement for community health workers at all? Or?
Sure. There is. I mean, definitely they'd like to have community centers get people diagnosed and get treated. One of the problems, though, has been, we just talked, for a while they were hoping HIV would be sort of a primary care disease. You go to someone who treats high blood pressure, asthma, just with your HIV, just like you would for those conditions. I already told you, there's so much out there now about how to manage these folks, what to do when they fail and have resistance. It's now swung back to where they feel, really in most cases, you really should have a subspecialist giving that kind of care. And that's where it gets sort of difficult. And each little community center can't necessarily have someone who's trained and sees at least the recommended 50 to 100 HIV patients in order to have expertise with the condition.
So in the recent study you mentioned, how many subjects were being tested?
Oh, in that particular, we have started somewhere around 200 or 250 patients on therapy. In the past 3 years, we have a population of about 750 patients, which isn't huge. To put them in perspective, in Chicago, the Core Center of Cook County has the most patients. We have about 4,000 patients. But this study was basically looking at folks who were also put on an exact regimen. We wanted to compare exact medication regimens. And I think the total numbers were something like 70 patients. And then we compared to the study, which had more patients, and then we just did the statistical analysis between the two groups. But they had to be on those exact same regimens. Okay. Any other questions? All right, thank you.